Thanks for coming, and I know it's really difficult to stay awake now, but I'll try to wake you up by being a little bit interactive. So we're talking today. We're talking about intersex. Ooh, that is really the ultimate frontier that we could be wishing to discuss, and clearing the fog of the binary myth. If anybody here is in the movie industry wants to make a movie about my life, we can call it Hermaphrodites in the Mist. So I just wanted to disclose, this is a picture from my cute face. Wanted to disclose that I really don't have any personal gain, except that I'm hoping that you take some information and some kind of rethinking with you from this talk. So what was the first question anybody ever asked about you? Correct. Is it a boy or a girl? So in about 200 to 300 births, that question cannot be easily answered in the delivery room. And what happens in that moment, that panic ensues. And this is basically when the path of being an intersex person for some of us, not everybody is diagnosed at birth, but for some of us begins. So here's another question. How many people in this room were hermaphrodites at one point in their life? Exactly all, because when we're conceived, for the first 6 weeks of our lives, we are omnipotential. In other words, we can become a typical male, a typical female, or anything in between. So we are conceived as hermaphrodites. We develop whatever our gonads and our chromosomes allow. And if there's some kind of confusion because one system or the other doesn't work, the default is female. But I've seen a lot of times that everybody is conceived female. That is wrong. It is actually hermaphrodite. So there's a few key questions, and you might actually be able to answer those already, but so as in this intersex and gender issue, that's something we'll be talking about today. Is gender and biological sex the same? You should already know this, but I'll still talk about it. Is biological sex binary? And these three questions are actually quite significant for the intersex population, and we'll see why that is. So let me talk about the basic a little bit. Biological sex, and a lot of times we like to do like this interchanging of gender and biological sex. We use gender for a lot of things. So here's a question. When somebody has a gender reveal party for an unborn child, is that a gender reveal party? Yes or no? Ha! What is it? Correct. You already got it. It's a biological sex reveal party, and why are we not saying that? Because sex is a dirty word. Ooh, we can't have that. So that's why a lot of times gender is chosen over the term biological sex, because it's just not the dirty word. It's much cleaner. So here's why you really can't use those synonymously. So biological sex in nature is primarily for procreation, found in nature. So we talk about chromosomes, we talk about anatomy, we talk about hormones. That is all biological sex. It's usually also determined upon conception. So, and it's typically categorized as male and female. So what is gender then? It's really an identity. So when do you know somebody's gender? When you really know somebody's gender? When they tell you? Yeah, that's correct. They have to tell you it's an identity, so you can't identify for them. You really have to ask that person what their gender identity is, or they have to, let you know by either their name of pronouns or maybe their name. It's not found in nature. So anybody here has pets, like a dog? Anybody's dog ever had puppies? Was the doggy mommy concerned if the puppies were boys or girls? Did she put pink and blue doggy treats out? No. No, because animals generally, even higher primates, really don't care about the biological sex of their child. They don't have different expectations from their offspring just because, you know, it is a boy or a girl. So it's a societal construct, and it changes with societies. What is considered appropriate for a male as far as outfit is concerned nowadays was completely different hundreds of years ago. And also there are a lot of societies that did not just have two genders. And these societies actually existed or still exist in some areas worldwide. Except maybe Antarctica. I think the penguins just refuse to do all that stuff. It kind of defines expectations that a society has towards the individual. You know, I don't know if you ever seen these birth announcement cards. I saw one that was amazing. They had this little teeny baby. There was this gigantic football right next to it. It was like, this football is going to crush the baby. Oh my God. So there was already an expectation there. You know, you saw that. You knew, oh, that's probably not a girl. All right. So it's assigned at birth based on biological sex characteristic. We like to, you know, attach gender immediately to biological sex, but that's not always the case. So typically the category is masculine and feminine, actually, not male and female. Alrighty. So, and this is kind of my thought, what biological sex in humans really looks like. You know, there's the typical male person, and there's a typical female person at the end, but there's a lot in between. So the binary myth, that's actually a term I created because it's just not true. It doesn't matter how many times somebody says there's only men and women. There are states here in this country that are trying to actually define what a man and what a woman is and define that there's nothing in between legally. So you still can't make humans binary. So intersex difference in sex development are examples for non-binary biological sex. It is not typical male or female. It just doesn't fit. Doesn't matter how many times you give treatments, how many times you do surgeries. It will never fit 100%. So the practice of medicine, unfortunately, that we have today is very binary. So from intake forms to lab values to certain tests that men get and women don't get and women get and men don't get. So, you know, that is a problem because it doesn't help non-binary people to go and see a provider if their needs are not what a typical male or a typical female has. So in order to kind of, so it's kind of this real, I mean, biological sex, you know, maybe people can accept that, oh yeah, sexual orientation, there's people who float around and it's on a spectrum. Maybe they can even accept that gender is on the spectrum, but it seems that people have a really hard time with accepting that biological sex is on the spectrum. And to reinforce that, basically, if a child is born with traits that are intersex traits, they are being pathologized and normalized. So interventions are supposed to maintain the binary that we have actually created and that doesn't exist. So hermaphroditism, just wanted to talk about that a little bit. What does that really mean? Because we hear a lot about that. There's often really strange things out on the internet about it. So really there are simultaneous hermaphrodites. The banana slug is one of them. There are sequential hermaphrodites. Clownfish, you all know Nemo, is one of them. Even they don't necessarily self-fertilize. They only do that if they end up by themselves somewhere completely isolated. They might resort to that. Nature has actually barriers there. Humans cannot do that. And there's been things out there where somebody claimed, oh, I'm a hermaphrodite and I just made my own babies. So this is not really true. There are ovotestes, which combine testicular and ovarian tissue. However, not everybody with a DSD diagnosis has them. They're actually fairly rare. And they usually only have one functional portion, and sometimes they don't function at all. So, and here we go. Disney lied. So, that is actually not, it's Marlene, it's Nemo's mother, because the largest clownfish in the anemone becomes a male, every clownfish is born male. The largest one turns into a female. So then from hermaphroditism, which used to be the diagnosis for people that we now have, say, have a DSD or intersex, that changed in 2006 because hermaphrodite was not necessarily a nice term. It was kind of derogative. So it changed with the 2006 Chicago Consensus Statement where the term of DSD was created. So that's what I just said. So it is still a controversial term because I use difference all the time, but the real word is disorder. I encourage everybody when I talk to them to practice resistance and not use disorder, but to consistently say difference or whatever they want to put in there that does not sound pathological. And because if you have this kind of diagnosis, it doesn't really make you disordered, you know. Except, you know, you probably think I am, but anyway, because I'm crazy or something. But it really makes you just different. You're just different. It doesn't mean that you're dying from different looking genitals or your chromosomes don't really match your phenotype that would be expected. So you're not dying from that. You're not horribly sick because of that. You're just different. It's an umbrella term for over 30 medical diagnoses. And that is another issue. They bunch together diagnoses where people really have an issue to even be in the DSD group, where people really don't want to identify with that. In particular, not with anything like intersex, because you could have somebody who has XXY chromosomes. So that's usually considered Klinefelter. These people are usually assigned male at birth and get testosterone because they don't produce a lot of testosterone. A lot of them have real problems identifying with intersex because they don't feel that that's a label they should have. They feel that, no, I'm a man, leave me alone, I don't want to hear about this. So there is a bit of a problem with bunching so many people into one group. So the new guidelines for treatment were also developed at that time. They mostly were applied to children. And why is that? It's because you're a child, you got your treatment, you got your surgeries, you're fixed, you're good, you're an adult now, bye, see you later, you don't need this anymore, you're normal. So basically, there is not much really done when it comes to adult care. So there's expert involvement in gender assignment. So I put the expert in parentheses because it's a little bit problematic. Because who is an expert? That's the real question. Who is the expert here? I personally don't have a problem with gender assignment. The problem that I have, and that a lot of us have, is the problem with surgeries to confirm that gender assignment at an age where a person can't really decide for themselves. So the other thing was that multidisciplinary teams at centers were created, and they're supposed to develop this treatment plan for this person who comes to them as a little baby from probably a place where they were born and they really didn't know what to do with this kid. So they're sending them to the center. So what does that really mean? That means that now instead of some people doctoring and trying to figure out what you're doing, there's a whole group of them. And it's very different. The treatment options are actually, and what is presented to the patients and their parents is very different depending on which center you go to. If you have a center that has a very strong emphasis on surgery, most likely you will get surgery. If you're at a center that has more watch and wait approach, you don't get that. So it's not like you're really getting a standardized treatment that everybody agrees on. It's more like, you know, top dog of the team is usually a urological surgeon, and whatever they favor is usually what happens. That's unfortunately the reality of it. And this is actually what the article I cited comes up. Definitely interesting. So what has changed since 2006? So there is a slightly lower number of vaginoplasties in childhood. Now, please digest this for a second. Vaginoplasty in childhood. Does a toddler need a vagina? Is that toddler going to suffer very badly from not having a vagina? You think? No, when does a vagina become more important? Puberty, correct. When somebody is grown to a certain, age and understanding and can probably make a good decision. I don't know who was here for the surgical talk on vaginoplasty for trans patients, but you heard that there's a lot of care that goes into that, including dilations. Do you believe that doesn't happen when you do it to a 3-year-old? Yes, it does. These kids are being dilated. Children being dilated, so to keep the vaginoplasty going over years and years, a lot of time, because they're small children, they have to be put under general anesthesia. So let's think about this for a while and see if that's really cool. But that number has decreased because some surgeons have seen that, yeah, there's a point that this is kind of invasive. However, there is no change in number of clitoral reduction surgeries. So what does that mean? If the clitoris is bigger than 1 centimeter, it's not allowed to exist. It needs to be chopped down because we can't have that. Clitoris larger than 1 centimeter? Oh my God, end of the world. That's right. So again, these surgeries are still done, and the patients who most of the time get these are patients with a CAH. I don't know who knows about CAH. It's kind of dysfunction of the adrenal glands, and a female, XX female person in utero gets exposed to testosterone and can more or less masculinize. So when these children are born, it's not totally clear whether they're boy or girl sometimes. Sometimes it's just a mild enlargement of the clitoris. However, interestingly enough, they have a very strong parent advocacy group called CARES, and what they really care about is that their daughter's clitoris is small. So I don't know who saw the Gender Revolution documentary. They actually had 2 CAH patients there, 1 child and 1 adult. CARES was outraged because the child did not have surgery and the adult was somebody who transitioned to male. They literally sent death threats to Katie Couric for doing the documentary. This is how controversial this is. So there is an increased assignment of male gender in most forms of androgen-sensitive XY DSD. So people with XY chromosomes that have testosterone exposure before birth and have testosterone basically function, they are more likely to be assigned male now. In the past, it was more like, again, the phallometer came out. If the penis was less than 1 centimeter, let's cut it off and make it a girl. Unfortunately, in up to 70% of certain patient groups, that didn't quite work out, and they did not want the female gender assignment. 70% in specific patient groups rejected it. So that has changed in some ways, and this is, again, where I cited this from. Physician barriers. I want to talk a little bit about that. What could make a physician be a little bit, kind of, I don't know if I can deal with this. So there is a clear medical knowledge gap. We don't learn, I went to medical school. We don't learn much about this. We really don't. We sometimes learn a little bit about, androgen deficiency syndrome and, oh yeah, those poor women, and they have to have their testicles out, and way back then when I went to medical school in the 90s, Stone Ages, they told us, they still said, never tell the patient. Sometimes don't even tell the family. So there was something that, was so bad you couldn't even talk about it. So at this point, we're trying to broaden the medical knowledge gap a little bit more. But you can see that if a provider sees somebody come in and they have a diagnosis like androgen sensitivity syndrome or any other DSD diagnosis, they go like, oh my God, I've never seen this. Oh, what am I going to do? Oh, specialist. And the end result of that is that the specialists have the same medical knowledge gap. It really doesn't make much difference. Then there's the ethic of trans or non-binary care. A lot of people just don't feel comfortable with that. And in particular with non-binary, because people are just going, so what are you going to be? Man, woman, what do you want? I don't know how to do this. So, because everybody wants to put you in some binary box, it becomes problematic. Then diagnosing versus pathologizing. Just because you give somebody a diagnosis doesn't mean that it's something you have to fix, right? I mean, healthy newborn is a diagnosis. You code for that, and diagnosis codes, what are they used for, so you get paid. Yay, money. So, but it doesn't mean that you have to intervene. So always keep that in mind. And of course, there's health system barriers. And part of the barriers is what I addressed earlier, that our medical system is so binary. What do you do with a woman? Somebody who was always assigned female, had testicular gonads, had them removed, never had a period, of course, because this person does not have a uterus, was not born with a uterus. So should you really ask them at every visit, when was your last period? And that happens all the time, even in specialty offices. So, so the health system with the whole binary categories doesn't serve this population really well. It's not just the intersex population, but in particular the intersex population. So where's the evidence? So research. So there's NIH funding in this field available since 2012. There is a large research project going on. It's called the Translational Research Network. However, most intersex advocacy groups have pulled out of that. Why? Because the same thing happened there that has been happening for decades, which is research on the population, not for the population. And that is where it's really lacking. Again, in general, studies related to LGBTQI between 89 and 2011, only 0.5%. And does anybody know what most of these studies were about? A guess? HIV research, correct. So it's important, but just trying to put that in perspective. So only few studies out there for transgender health, less for DSD, and when it comes to younger or older population, and especially the older population, there's really almost nothing out there anymore. So I found that out, and I thought maybe I want to do a research study, at least a literary review, and I teamed up with an anthropologist from University of Ottawa who does intersex work, and we started this follow-up study, the good, the bad, and the ugly. So what we did is we're doing a literary review study including over 100 peer-reviewed articles. This is more extensive than any study that is ever done. We're following up studies performed by surgical centers, other specialties who just looked at patient and their surgical outcomes or treatment outcomes, assessed patient satisfaction, and also we looked at literary review studies on all that. And we basically looked at any surgery that anybody with a DSD diagnosis could potentially receive as far as their genitals/gonads are concerned. So I don't believe that has ever been done before, because usually it's focused on one surgery, for example, on vaginoplasties. This time we're trying to really get the big picture. So what we want to find out is, what do the surgeons say about their results and their follow-ups? What do the patients say if they were asked, or their caregivers? Very important is that to look at the interval between surgery and follow-up study, because if you do surgery on a 5-year-old and you do a 10-year follow-up, how old is that person? 15. Are they going to be able to tell you much about their sex life? Hopefully not. So So that is one of the big limitations that some of these follow-up studies have. So what we found, and this is preliminary findings so far, so surgeons are generally very satisfied with the results, and interestingly enough, it's cosmetic. So cosmetic outcome is really what they don't care about function as much. Actually, I read at least one article where the surgeon specifically stated, well, function is not that, it's really not, I shouldn't be asking about that. So that's one of the things we found. Then patient caregivers a lot of times are not even being asked, or they're being asked closed questions like, do you like this? Is that great? So what are you going to say when your big-time surgeon sits in front of you at the desk? Are you going to say yes or no? Probably yes. And in particular, if you're just a parent, you don't want to argue with that guy. So then this is the limitation. A lot of times patients that are being followed up are under 18 years of age. And unfortunately, when we talk about genitals, we talk about sex, right? I mean, that's what they're there for, I guess. That's what I thought, mostly. And if you don't talk to an adult population and you don't follow up the adult population, you're really not going to find out what their sexual function is, or if they're satisfied with their sex life. Or even questions like, are you heterosexual? Are you homosexual? Are you asexual? Not even that is being asked. So the interesting thing that we saw is there is a difference between those patients that had male assignment surgeries. There's a much higher emphasis put on not just cosmetic, but function. So apparently, the surgeons care more about their male patients' sexual function than the female sexual function, which, kind of, it's almost not a surprise, right? Okay, so are people with intersex or DSD gender dysphoric? Because a lot of times what happens is when people speak up like I do, and I say, well, maybe surgery is not that great, especially when you do it on a little kid, people get very defensive because they don't want to appear as the bad guy. Oh, I'm a surgeon, I'm doing I believe that. I believe that surgeon's doing the best that he can, but I'm pretty sure there's other patients out there who would need that surgeon just as much or more, actually, than those intersex kids. So we're being called these gender dysphoric people. And I already touched on this. And 70% of female-assigned intersex DSD individuals with XY chromosomes, testosterone sensitivity, and urinary tract conditions have transitioned to male or at least rejected a female assignment. That is huge. 70%. So this is one of the things that made people actually change think about gender assignment. In general, when you look at the intersex DSD population, you still have a transition rate of 25 to 30%. Now look at that and think general population. If 25 to 30% of everybody was transitioning, wow, would that not just blow society apart? So, that is quite a number. So biological sex just does not determine gender identity. Gender identity is independent of chromosomes and anatomy and physiology. We all know that. On top of that, how do you gender somebody who already was born with a non-binary biological sex? And that's really the problem. If you're not born inside the boxes that we have, and that's what the US law says, you have to either check the male or the female box on a birth certificate. If you don't fit in there, how can you even be called gender dysphoric? Because you weren't given the right choice in the first place. So gender identity, nature versus nurture, I just wanted to bring that up. That more and more evidence is found that gender identity is not something that we choose. A lot of people accuse people, your choice, you chose the transition. Well, so it's most likely something that in some way is already present at birth. We don't know how, but It's not something that we acquire. And if you think about your own gender identity, and you think about you probably at around age 3, 4, 5 already kind of, trended towards a gender. Most likely it was, pretty much along with the sex assigned at birth. But you knew that. You might not have known that there's different parts. You didn't know anything about sex for sure. So, that shows us this comes from something else. This does not come from external. So I wanted to talk a little bit about intersex and transgender. I call that the inverse paradox. So intersex people, so they receive medical interventions, surgeries, as early as infancy to conform with a biological sex assignment. Of course, the patient, if you're a baby or a child, you can't consent to that surgery. It's just being done. Your parents consented. So these surgeries and treatments are generally covered by insurance. No debate, no discussion about that. So what happens if that intersex individual grows up and says, well, you did all this stuff to me, but I don't think this is what I want. So all of a sudden, what happens is they end up being called gender dysphoric. And all of a sudden, they have to go a path that is a trans path. So we're creating transgender people, basically, right there. So, and what do transgender individuals experience? So this is somebody who is not intersex, typical male or female. They are being scrutinized. They have to undergo all kinds of, therapy for surgery, for example. They have to constantly defend themselves and say, oh, but, this is how I feel. I mean, who are we as physicians to tell some patient of ours, this is who you are, and I know who you are, you just don't know who you are. I mean, that's basically what we're saying if we're not acknowledging the identity of a person. But it always happens, and it's very difficult for a lot of trans kids and teenagers to get treatment. And it's very concerning for them when they come into their teens, where their body does things they really don't want to happen. So it's almost, again, isn't that inverse to what happens to intersex kids? So then, I already said, even as adults, you have to overcome various obstacles. Some of them are not as stringent anymore as there used to be, but it really depends on which system you're in, where you live, and the obstacles can still quite be very high. We're just lucky in California here that we don't have so much obstacles, but we have enough. I mean, if you were at the talk and you heard that there's only basically 2 centers, Dr. Garcia said 2 centers here in California that do the surgery. That's, wow, really? That's it? How many centers are in California that do intersex surgeries? More than that. So right there, it's like, you're doing one but not the other. Interesting. So, and then now it's a little bit different again. In California, there's a law that insurance companies have to cover, but they can charge you for that. They can make your plan premium go way up if you also want to include intersex benefits. Transgender benefits. So, yes, you can get it here, but there's other states where you can't. So, a lot of people still have to pay out of pocket. So, not covered by insurance. So, my next question was, where do we go from here? What really needs to happen that there's more awareness what's going on? So, just understand that sex/gender assignment at birth is really not an emergency. The baby rarely has a condition that needs immediate treatment. Yes, there are some that need that, but it's not necessarily their genitals. It is other things that need to be taken care of, so they're okay. But most of the intersex babies born, they eat, they pee, they poop, they cry, sleep. The basic functions of the baby, they all work. Maybe their genitals look a little bit different. Maybe they have internal testicles and just look like a girl on the outside. But that does not kill them. It does not interfere with their development. it's not that they're impaired by that. So, and like I said, I don't have a problem with an assignment. You can, if you have to check one of the two boxes, okay, do it. If you have to give a name, do it. Maybe you want to give a more ambiguous middle name. Might be a good idea for future purposes. For anybody, anyway. But you really don't have to do any surgical interventions that are not reversible. And that is really the problem. Because these surgeries, as I explained, are not life-saving. They're cosmetic. Which is interesting because usually we don't pay for cosmetic surgery. Anybody who wants a breast augmentation usually has to pay for that, right? And we don't even pay for newborn circumcisions anymore. People have to pay that out of their pocket. So, but we're still happily paying for these intersex surgeries in childhood. So the other thing that's often done to intersex people at that point is they're being sterilized. If you remove the gonads, there's never a chance that this person can procreate. And people might say, but they can't, they shouldn't be. Yes, they could. There's, for example, an interesting study that I read about somebody who had a partial androgen insensitivity syndrome, but was assigned male at birth. What happened is that person was able to father a child through IVF. So DSD does not equal being sterile. The lack of treatment towards preservation of fertility is what sterilizes a lot of intersex individuals. We have to keep that in mind too. So what really is my pet peeve is the education of the general population. To start here at this level is almost too late. You should have heard about this in high school before you ever procreated or anything. You should know, yeah, you might have a boy, you might have a girl, but you also might have a kid that's neither. And that's okay. Because that will take a lot out of the stress that I talked about at the first slide in the delivery room when you can't tell. If you already heard about it and somebody says, oh, we don't know what this is, you just say, oh, it's okay, we know about that. Give me my baby, it's fine, don't worry about it, we heard about it. They told us in high school. How different would that be? So school would be the first place where I would start, but also educational materials in OB/GYN offices. How many flyers does a pregnant woman get? Informational brochures, this and that. Can't we just make one that says, well, what if it's not a boy or a girl? Is that too much to ask? Would be easy. You could just tell them that's a possibility. So, and of course, medical students, medical residents, which is, who I lecture to most of the time, because you guys, who is a medical student here or a resident? Yay. You guys are my hope for the future, that you will get this and not repeat what your previous generations have done. And maybe also start listening to intersex people a little bit more. And the other thing is that we really need to create an evidence base that helps the intersex population. It's not just about preventing surgeries and all that. What happens a lot of times is when an intersex person grows up, maybe they go to a special center as a child and they're being treated, but once you're an adult and you're out of it, bye-bye, boom, you fall off the face of the earth. For a lot of people who had their gonads taken out, who need hormone replacement all their lives, that means they either have to find somebody who can tweak that for them, or they'll just go without for a lot of time. And there's a lot of people who have gone without seeing a doctor because they were so tired of it, and they didn't want the same treatments over and over again, and they didn't want to hear the same arguments, and they didn't want to re-educate every provider about them, and they just don't go anymore. And we know that's not a good idea, especially when it comes to preventing any chronic illnesses, be it osteoporosis, heart disease, etc. And with that, live long and prosper. All right, I think it's time for my panel to come up. Anybody have any questions that are really pressing at this time? Please.
Rough population size, 1 in every 2 or 300 births?
So 1 in every 2 to 300 births have what is called ambiguous genitalia. Preferably, I would just say a variation of their genitals. But there's more, because there's a lot of people that are diagnosed later on. Some at teenage age, girl doesn't get her period, so eventually you find out, oh, that's because there's no uterus. Oh, okay.
So that one or 2 to 300
right.
is an at birth, where it's
correct.
More.
It's about 0.5% of the general population, which is the same as natural redheads. Okay? So, natural redheads and intersex people unite. And we have twice the population. Alright. So, here's my panel. And here's something. I want all the panelists who have XY chromosomes to raise their hands. Ta-da! And here we go.
Hi everyone, good afternoon. Thanks for having us. My name is Cynthia, and I currently go by, if anyone gives a crap about pronouns, which I freaking hate that question, I really don't give a crap, but I go by she, her, hers, but there's a slash between the S and the H on each of the she, her, hers. And I was born in 1965. I have 46XY DSD. I used to think that I was partially insensitive to androgens, and in my journey of figuring out what the hell is going on in my life, as it pertains to my intersex traits, that was revealed through molecular testing at UCLA through a researcher that many of you may be familiar with, Eric Valland, who used to be affiliated with UCLA, and he's now in DC with a big grant that he got. Revealed that my genotype is in fact 46XY, and so I kind of started my process of learning about my intersex traits and my medical diagnosis about 10 years ago. But I was at birth in 1965. I was born in Chicago, and I have a physician father who is a pretty smart guy. Went to Northwestern Medical School, was top of his class. And my mother was a nurse, and so they're pretty smart people. But I was born and thought to be a boy because of the phallic nature of my genitals. I mean, for the same reason as Michael pointed out, there's the first premise of your life: is it a boy or a girl? And you look at a child, and it's like, well, yeah, that looks like a penis, or that looks like a vulva. So I look more like a boy. But it didn't take too long or too many diaper changes for my parents to figure out that I was a little different down there, and I did already have 2 older brothers. So between my father being a man, a doctor, and having 2 sons, they're like, Houston, we have a problem here. And so I was taken into what it was then Children's Memorial Hospital, which is now Lurie Children's Hospital in Chicago, and was taken in for an evaluation and workup. And, excuse me. And the team of doctors, I had a pediatric surgeon, pediatric urologist, and a pediatric endocrinologist. And their evaluation of my ambiguous genitals was that I was far too complex to create a boy. That essentially I just didn't have what it takes to be a man. My trajectory for manhood or maleness was not, I would not be successful as a male, because my genitals essentially couldn't be fixed. So as was the case in the time, it's easier to make a hole than to build a pole. And so there was surgery to remove my very small testes, which did produce testosterone, and my body did respond to, and still does, and to minimize the size of my phallic genitals, which were small, but were definitely more phallic in structure. And so, flash forward, I, in my 40s, was like, after years of being on estrogen, which was Premarin, which an earlier doctor, if you heard Dr. V, she said, anybody on Premarin, get off of it like yesterday, because the stuff is crap. But having that been my protocol for most of my life, I started on a journey of exploring the possibility of testosterone, and so I've basically been on testosterone now. I'm on IM injections and responding to it very well. Whether or not I transition, I still don't know, but testosterone is banging away at my body, and I'm shaving more and definitely feeling that that's a better fit for me. But I still don't feel like I'm specifically transgender. I mean, I don't feel dysphoric per se, but I relate to being on testosterone. And so for me, my victory with the medical community is that I've been able to get on testosterone. I'm with Kreuzer, and they're pretty progressive, but Kaiser's pretty binary. They like things to be very black and white because they like to keep the cost down, you know? And so they like things to be predictable and normal and repeatable and observable, you know, every case. So I'm still navigating my way through that, and you know, it's still an ongoing thing. I'm 52 years old, and it's still unfolding. So I will happily answer any questions in time, but thank you for your time.
Hey guys, Tanya Armstrong, actual PAIS, partial androgen insensitivity, XY. I was born kind of smack dab in the middle, wholly ambiguous. I was also born with cancer, bilateral Wilms tumors. At the time, I was diagnosed at 8 months old. I was born with it, but they didn't find it until my parents found really lumpy sections on both of my kidneys. So they did the clitorectomy because, God forbid, I have something larger than that as an infant, and then told my parents to never tell me because no one will love me if anyone were to find out. And then when I was 11, I started going into Children's Hospital for the follow-up that would eventually give me the vaginoplasty because I had no opening. And that's actually when I found out, is when the nurse came up and looked at my chart and said, "Oh, sweetie, when did your parents decide to make you a girl?" And I said, "What?" So I had that when I was 12 years old. I had the first one. It was a sigmoid colon vaginoplasty. Fucking sucked. They had to put me under for dilations, as Michael alluded to many times. They never took. I have figured out that I believe what happened is the portion of my colon that they took was right where there was one of those little sphincters that helps to move things along, and so that was why it would never stay open. So I had a second vaginoplasty when I was 15, and that doctor found some Mullerian remnant in the back, way past the sigmoid colon, and kind of figured out that that's where I was getting some of my urinary issues. There was a pocket of tissue that was merged with my urethra, and so urine would just collect there. And so it would collect there, and then I'd move a certain way, and it would cause a huge infection. And so it was great on him that he found that and fixed that. But then he also decided while he was there to fuck with my urethra and put it down into the new vaginal opening he was creating, which caused a bunch of incontinence issues and bullshit. Of course, didn't ask me or my mom or anything, just kind of did it. So I had the second vaginoplasty, which doesn't need dilation, but it still doesn't really work. I mean, like, first off, I don't really like dudes, and second off, even if I did, they'd have to also have a DSD in order to fit, to be honest. So that didn't even really work. I started getting the follow-up study questions when I was 16 years old. There was nothing on them about the clitorectomy, nothing about whether or not I had sensation or I could achieve orgasm. They didn't really care about that. They just cared about whether or not I needed dilation, and not needing dilation was then linked to success. Yeah, exactly. Can't. No. And I lost my train of thought there. Anyway, so it ended up, none of that was really successful. I'm essentially the poster child for always and poise. I have to wear pads every day because they use the sigmoid colon tissue, which is constantly producing lubricant. So, I'm just there to give always money, you know. Gender identity, I don't really give a shit. I use she, her because it's on my driver's license, and I don't feel like explaining intersex stuff to my people at work. I'm a chemist, and I don't need to bring that stuff in there and have everyone there questioning me about that all the time. I also open for any questions. I can't be as dope as Cynthia though. I try.
Hi, I'm Alice. I was born here in LA. I was born in 1989 at Children's. Actually, back then it was White Memorial Hospital around here. I have androgen insensitivity syndrome. I have XY chromosomes. At the time I was diagnosed with complete androgen insensitivity syndrome, so thankfully they decided not to do a clitoral reduction, so that's still intact. Yay for me. Yeah, so that's good. But they did decide to do a gonadectomy at 3 months, I think. I'm not really sure because I haven't been able to get medical records for that time. By the time that I found out about it and started trying to understand it for myself, they were like, "Oh, your records have been destroyed." So, yeah, that's fun. So since then, I found out when I was 12. I went in for a physical because I had to get a physical done to play soccer outside of school, and that's when they kind of took my mom out of the room and were like, "Hey, did you know this about your daughter?" And she was like, "Yeah, I know it." And does she know? And they decided to tell me right then, but they kind of just gave me a bullet point, "Oh, you don't have a uterus, and you're not going to have kids, you're not going to get a period, but we're going to send you for all kinds of testing and stuff like that just to confirm that you're XY and stuff like that." So pretty much my adolescence, high school time and everything like that, was just being on Premarin, which was awful. Being on Premarin and, being told by doctors that "Oh, you're just a normal girl, everything's fine," and everything was about my future husband, and "Oh, your future husband, you won't even be able to tell that you're different down there," and blah 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 blah, stuff like that. But finally, when I decided to look into it and read for myself, and that's kind of when I learned all the stuff that happens to intersex people, and I met other intersex people, listened to them, and shared stories, and found out that a lot of us went through the same things, or similar things, and I'm currently, I do identify as female in terms of pronouns and if I have to choose one, but I don't I always tell my doctors that even though I present as female and I put down female on everything, my body is not female. It's not XX. I don't have a uterus. I don't have a cervix. I don't have anything that you need to do certain things for or ask about, or when they think of things, they always think, "Oh, in terms of a female, you want to be in this range of this and that." And I tell them "But I'm not a female, so can I just kind of have shit custom to me, a little bit, fuck, sorry." Yeah, so that's constantly a bit of an argument with people, is just that they can't get past the "Oh, but you look like a girl, so I feel like I have to treat you as a woman, and you want to be female, right?" It's just very confusing for them because they can't sort of think outside the binary in terms of how my body works and what I want for myself. So currently I'm on testosterone injections. I have been for a few months now, and it's been working out great for me, way better than estrogen, so I'm feeling pretty happy about that. So that's about it, and I'm open to questions and whatever.
I'm Heath. I use he, him pronouns. I have late onset CAH. I was born in 1966 in, I didn't know this little town, but in Ohio, a little town in Ohio. And at birth, I was ambiguous enough that my mother, the first words that were spoken when I was born was, "It's a boy." but the doctor immediately corrected that to it's a girl, and so I was assigned female. I do have, it turns out, XX unambiguous chromosomes, but I didn't know that until I was 49. I didn't have any doctor diagnosing that or telling me at least that I had an intersex condition until I was 48. But something was odd. I had to be put on female, late onset CAH, congenital adrenal hyperplasia. It appears, I know because there are other female assigned people in my family, including a very young one. Since this is being filmed, I'm not going to be specific, but they also had a similar experience in the puberty. So for me, what happened is we seem to have early onset, at least in my family, we have early onset puberty very, very early. The youngest family member that has this has fully gone through puberty at 10 years old. And the puberty, as it was for me, it was when I was 11, but hairy chest, facial hair. I'm a grower, not a shower. Something showed up, I wasn't surgically altered as a child, is what I'm getting to. So I'm very fortunate. A lot of people with CAH, it is much more obvious at birth, and they're surgically altered at birth. So that didn't happen to me. But I was put on female hormones to live in my birth assignment so that I could menstruate. I did have a uterus. I did have ovaries. They were really tiny and not functional, but I don't know what the name of the drugs were because I was put on them, very young or whatever. I think they were just traditional but very high dose birth control pills, and I was on those for 37 years. It was a really long time. 32 years. I'm sorry. 32 years. I was on female hormones. It made me very ill. Now I know that with CAH, like my body just doesn't do estrogen and progesterone. Not only doesn't make them, but it doesn't handle them well. It doesn't make me feel healthy. So because of medical complications from that, I had all the inner stuff taken out. But that didn't happen again until I was 48. That was when they started with the diagnosis. What else can I say? I was able to have children, two children. It was very difficult. I had to have a lot of hormonal intervention, including during the births. Both hospitals used higher doses of Pitocin than they had ever used with any other patient for me to get those babies out. But I do, you're medical, so I'm just sharing this, things you might encounter. Yeah, but other than that, I function sexually as male without any intervention. I'm very grateful for that. But I'm very concerned because of my child. Because of the other people in my family that have this condition, I'm extremely concerned about the way that doctors pathologize intersex conditions. I, for example, was never told, and like I said, until I was 48, that I might have an intersex condition. And in fact, what I was told instead, from the time I was 8 years old, it was that I was mentally ill. And I was in an HMO system that I won't name, but for 20 years in that system, I was told I was mentally ill, put on psych meds, continued on the female hormones. Since I stopped taking female hormones, not only did I regain sexual function as a man, but I also have not been ever diagnosed with any mental illness. So, yeah. So there's a lot of things that can happen to children when they're pathologized for having an intersex condition. I really don't want to see those things happen to children anymore.
Hi, my name is Severn Graham. I'm English, not Australian. I know it's 50-50 which way you go with that. Thank you so much, Michael, and everybody for being here and doing this, and thank you all for attending. It means a lot that people show interest in changing things. I was born in England in 1969, and I was diagnosed as intersex, unbeknownst to me or my parents, when I was 8 years old. I went to see the world eminent gynecologist, Sir John Professor Dewhurst, who was God in a white coat. I had a gonadectomy. I didn't find out that until I was 24. I was told that my ovaries were going to become cancerous and had to be removed, so I have the same condition as Alice. That story has been enormously harmful for me psychologically, because I felt since I was a kid that the Grim Reaper's stalking me and that I should have died when I was a teenager. I have done. I can't tell you the whole story because we haven't got time. But I discovered the truth when I was 24. I went into a huge shame spiral downwards. I already had an addiction. I'm half Scottish. I think genetic predisposition was there, but my addiction went crazy, and I ended up in rehab in 2001, nearly dead from my addiction, and I've been sober since then. I came to live in Los Angeles 2 years ago, and I've been doing creative work again, having been an addiction expert for the last 10 years in Europe. And I wrote a play last year called Angels Are Intersex, and in the process of writing that play, I realised that I had to let go of my female name, and I had to own and embrace my male side, because my male side had been denied from a very young age. I felt male when I was a child. I didn't feel female. I had boyfriends and liked boy things, but I was pushed into the pink box. And so I changed my name after writing the play from Sarah to Seven, and I changed my pronouns to they, their, them. That has been very healing, but it's also really opened the floodgates to a lot of grief around what happened to me, and that process is unfolding. I found out today that I could have possibly been fertile. I didn't know that until today, so it's an unfolding story. I still get clinical depression. I've spent the last 5 days in bed, having been back to England and just done a very in-depth interview around everything that happened for a documentary. And so I've basically spent the last 5 days in bed. I get suicidal ideation. I don't want to pick up drinking drugs. I go straight to suicide. So it's still painful. It's still a process of healing. I'm committed to that process of healing. And thank you everybody for being here.
Okay, we're now.
Questions?
That's right. No, questions.
Get those hands up. Yes. Here we go.
I work in administration. This question is for the whole panel. And thank you very much for being here. How would you like to see the registration process go that would be respectful and yet transparent? How would it look to you?
I would say that sometimes, like I've noticed that, like I think I even went to Planned Parenthood recently, and they have a chart, and they have like wonderful new additions to the gender category, but for sex they still want you to choose male or female. So, and I kind of had to like still write all over that I'm XY, but you know this, and so I would say something like male, female, other, or intersex even would be great, and then from there follow-up questions would be great. Don't assume something from someone just by looking at them, like, because like for me they constantly ask me like, when was your last pap smear, when was your last this, and or your menstrual period. So don't assume that I have a uterus, don't assume that I have a cervix. I mean, it's fine. I mean, it's for my health, of course. It's like not like I'm gonna go punch someone in the face because of that. I mean, it feels like it. But or there's other like CAH people that have uteruses and stuff and don't get asked certain questions. I don't. It's with intersex people, we're all over the place in terms of what organs we do have, don't have been removed. You know what I mean? So just be sort of sensitive to that in terms of, and I probably didn't answer the question.
That's why I'm thinking maybe assign sex at birth, pretext, and then you tell us.
Mm-hmm. Yeah, that's good. And then also read your paperwork before walking. Like, have the doctors just be like, read the paperwork before you walk in. Because the same thing. Like, I have been asked 4 billion times when my last period was. Is there any risk of you being pregnant, Tanya? No, there still isn't. No, I didn't run into Jesus yesterday and he didn't, wax on, wax off and give me a uterus or something. No, still have never had a uterus. So it's, like, just, it's in the paperwork. Just read it. Just have them read it. Give us the box, and then make them read it. That's really the big thing.
Like I said in the beginning, intersex means non-binary biological sex. And what I really feel strongly about is that we have to acknowledge that officially in the medical field, and at least, for the least, put a third box where it says biological sex. It's all fantastic that you can, have all kinds of gender expressions, but that doesn't help you when it's not gender that is your issue to begin with, where it's actually biological sex. And just that acknowledgement might open up whole new perspective, even to providers and those people who have to read those forms and who then have to put the data in and create the awareness that we don't have right now, that there is more than just these two biological sex boxes.
And Alice touched on this. If you have a patient who's coming to you and asking about, hormone protocols, disregard your reference ranges. So for me, I'm biologically male. I'm socially female only because there's not another option listed. So Kreuzer sees me in the F box, And so it's like, if I'm saying, yeah, I'm feeling like I'm yo-yoing on my hormones, and then they want to see blood values, and you're like, well, your reference range for this, it's like, reference ranges aren't really going to work, for us per se. It's going to be more like, what are your symptoms? I mean, if you're experiencing highs and lows, and so that it's, to me, it's the concept, and I think this generation is going to be the first to know about non-binary medicine, medicine that is non-binary. And that's like a whole new world. I mean, medicine is about understanding what is predictably human, that this is what we understand for the female of the species, and male, it's like, well, yeah, but there's a whole range of everything in between. And so, right now, this microphone. This is a non-binary microphone, goddammit. This thing needs some testosterone.
So anyway, I can project pretty well. I'm always told I'm allowed now, but I don't know where I was going with that. But just to say that, it's really about what your patient is feeling, and not about, which way they want to go. Because like I said, I'm sort of like the last to know. I probably should be on a transition trajectory, but I'm like such a dipshit. I'm like, yeah, I'm okay. But that's maybe where I'm headed. And so, like, the doctors are looking at me going, where do you want to go with this? So I have to tell them where I'm going, even though I don't necessarily, it's like, well, I don't really know.
Testosterone seems like the right thing to do because I had testicular gonads and I am XY. Doesn't that make sense? So it's kind of, I think sometimes your patients, are not going to really know all the answers. And I just sometimes feel like I'm so expected to know, like, everything about my case when it's like, we weren't told anything. And so working with a clinician that is open and is collaborative and cooperative and just, is so healing, is very healing. So thank you.
Any other questions?
Or any other answers? I would like to say, I just want to bring attention to the fact that USC, and especially the Department of Health Services, this hospital over here at LAC USC Medical Center, is the second largest facility in the country that does what we do. There are 17,000 employees there and 32,000 employees in the Department of Health Services. And they are shit. They're shit. I mean, I've filed one complaint after another, and it's literally very, very, very difficult. So the more attention and focus that can be brought to that organization to continue to implement change that will bring attention to healthcare needs for our community would be most helpful for us who are on this committee trying to force these.
So let me ask you this, because I do LGBTQIAA competency training. I just talked to the San Diego Gay Men's Chorus membership. I will be speaking at the Sempra Energy diversity and inclusion conference in March, exactly on that topic. I mean, what it seems like you need competency training for your employees, so they understand and they can, especially when it comes to non-binary, everything that's LGBT is halfway understood, is a better understanding. But once you get to QIA and you say non-binary, people are just like, what? We didn't have that in my time. So, that's...
You can't even get them to LGBTQ.
Okay.
We have administrators who flat refuse, and I mean at the top, chief medical officers at the top, and especially since Mitch Baxter since he left and went to New York, we're flapping in the wind.
And you will have patients that have non-binary designation on their driver's license now. You realize that since January 1st, people can do that.
We can't even get the changes made. I'm talking about this organization is just refusing to change.
Wow.
My supervisor called me a faggot. Will we be fired? Probably not. He texted it to me.
What?
I just want to be honest.
All right, what's their
about
name,
myself. I just want to be honest about it. They can't fire me either. I just want everyone to know what we're up against here in California.
Oh, yeah, I know.
This is an outrage.
Yeah.
17,000 employees.
So, like I said, you just probably have to keep on digging, because maybe try to use laws that are in existence in your favor, and maybe find some legal support if that really doesn't work any other way.
I think I'm more interested in staying and continue to advocate and following the complaints with the county policy of equity.
Okay.
Because I have a loud mouth and a loud voice, and I don't do anything. They can't fire me. So I just want everyone to realize that even though we're in Los Angeles County, where all these laws are being passed, we have an infrastructure in place here at USC and county that refuses to change and advocate for our rights. That is the truth.
We know all about self-advocacy when we walk into any place, because we have to.
Thank you for
That's an inside perspective.
Yeah.
That's an inside perspective. And there's a thing called just culture. There was a seminar that the attorney did this morning talking about religious freedom. We kind of already do religious freedom here. They call it just culture. So if someone doesn't want to take care of a certain person at this facility, they don't have to. They can't get fired. Just like my supervisor probably will not be fired.
You're not alone.
Yeah. Let's just get it all out. Let's just all be honest. There's a facility with 17,000 people. How many people show up at the LGBT committee meeting monthly? How many people show up? 6. At most, tops.
That does.
Yeah. It's despicable. It's sad. It's sad.
So our plan, our strategy is currently, I'll be speaking as chair of our committee, I'll be speaking to DHS leadership next month about making this cultural competency mandatory. It has to be.
But we're not going to be able to do it alone. I mean, this video has got to make it to the
We're
top.
self-advocates, keep it up.
And that
Keep it up
cultural
because-
competency, it comes down to the community level. I live in Carlsbad, and my small little LGBT center is in Oceanside, and it's a small one. It's not even the San Diego main center. And their executive director goes out to police departments and health, departments of doing cultural competency. And we've been lucky because they've included the I. For the longest time it was always just LGBTQ, and it's like, well, I needs to be in there, and and so I think that's happening. But even in California, it's
Okay.
I was just wondering if you could go back in time, or even in the present, if you had a healthcare provider who asked you something that was super offensive, or that you wish they had or hadn't asked, or kind of how can we learn from all the mistakes that people have made and offended you and all of that?
All right. Number one takeaway when you're treating an intersex patient.
period.
Don't ask about the goddamn period. But really,
She is not menstruating. Thank you.
when you find a person who's intersex and they have a condition or a phenotype that's something you've never seen before, you never heard about it in college, don't go get all your fucking friends and bring them and like lift my goddamn sheet up without even consulting me. Because you know how many fucking times that happened? Pardon my French. A lot. They come in, oh, let's go, oh, holy shit, this is, I've never seen something like this before. Really? And who did your surgery? Really? Just every single time I would wake up from like being asleep, or I'd wake up from anesthesia and there'd be a bunch of people poking around under there that I'd never seen before. And so it's, don't do that.
And there was another question over there?
Yeah, I was just curious about, multidisciplinary programs for intersex, peds patients. I know that's kind of big. I come from UCLA, and we're really big on multidisciplinary programs in order to really provide comprehensive care, comprehensive decision making, and comprehensive review of benefit, risks and benefits of different treatments, and how you feel about multidisciplinary programs, and what would be the dream or the ideal kind of program for a pediatric patient, and how we can kind of guide them through being intersex.
Hi. I had the same experience as others in terms of seeing a doctor every 6 months, and I saw Dr. Dewhurst for quite a long time, every 6 months, then different gynecologists, and a lot of the a lot of that was for the doctor's benefit, not for my benefit. However, I got to go to UCL in London to Dr. Conway's team, Dr. Conway and Dr. Sarah Crichton, working together in a multidisciplinary team, and it made a huge difference having a one-stop shop and having clinical experts who then could all kind of work together as a team. It felt like I was actually being held for the first time. There's a psychologist in that team as well. However, the clinic is based right next to the gynecology area of the hospital, and you have to walk past the nursery with all the children to get there, so that's quite triggering. But I think that approach does really help. One thing that obviously comes out of having a clinical approach like that is the fact that evidence gathering can happen, but still I find myself in a situation frequently where they don't really know what the long-term outcome. I was on Premarin for many years. I'm now on estrogen with a little bit of testosterone as well, and I still feel like a laboratory rat a lot of the time because the level of information is not there. The evidence base is not there for people of my age going forward.
Is it okay if I speak to the last question? So, having the two things that left to mind, things not to do. Going to a urologist, having him poke a metal rod down the hole on the tip of my penis, or enlarged clitoris, whatever you want to call it. It went halfway down. He's shoving this metal rod down. Do you know your urethra doesn't go all the way through? He could have asked me that before he stuck this thing, jabbed it into my... So, yes, I'm intersex, so, there's an opening somewhere else as well that was actually, so, things like that. The other thing was, don't assign someone's gender based on what sex they're attracted to. Because when I was put on female hormones at 15, the question was, who do you want to grow up to marry? Well, I'm attracted to men. I'm only attracted to men. I knew that. At 15, you kind of know. And it was like, okay, then you need to be a girl then. So I would hope we wouldn't need to say that to this crowd, but that does happen. And I want to make sure it doesn't happen to other people.
Just to follow up with you, I know there's a lot of questions about periods and last periods where people, I don't know how you kind of were presenting at your appointments, but were people asking you about your periods?
Yeah, that was one of the reasons I was put on female hormones. So like I said, I had little ovaries, a little uterus. So congenital adrenal hyperplasia means that I didn't really process female hormones enough to really feminize without having those applied to me with hormone therapy. So yeah, I would get asked questions. Once I was being feminized with hormones, I had periods. So that was an appropriate question. What happens now, though? No, people don't ask me that now. They assume I'm male. And like I said, with urologists doing that to me, that's whatever. So yeah, the question that I might get asked now, but I'm not offended by it personally, is what about prostate exams. So I had a uterus. You all know, you're medical people. The uterus and the prostate are the same gland, depending on how they develop, right? Right. For some people. Yeah. Okay. So anyway, you usually get one or the other out of that blend. Right. So I did have a uterus. I don't have a prostate. But that's not an offensive question to me, but it's a good thing to be aware of.
I was going to ask you, so does UCLA have a DSD team?
You know what? That's a really good question, and I'm going to find out. So our current multidisciplinary program is held within urology, and we have like a genetic counselor, a psychologist, an endocrinologist. But I will find out, because I think for me, coming from the medical perspective, one, I want to say thank you so much for sharing your stories. I have some other questions I wanted to ask you guys one-on-one in terms of like your treatment Premarin and your experience with your urethra and your infections, because that's important for us to know for patients in the future. But I think that the key takeaway for me is how we can improve our multidisciplinary program and
So,
what kind of services we can
Let
provide.
me tell you a little bit, because I kind of touched on that. The problem with the DSD teams is that a lot of times it depends on the lead surgeon on the team. UCSF has a DSD team, and their approach is very much, their surgeon's approach is also very much watch and wait. So you don't get a lot of surgery. I was at a conference in Cincinnati at Cincinnati Children, where the surgeon is a guy from India. He actually goes back to India, performs hypospadia surgeries, and comes back to the United States and is hailed as this hallelujah. I'm always wondering, who does the follow-up on those kids? You know, this is what goes through my head when somebody does like. So that team is very much pro-surgery, because this guy, hey, let's make this kid a real man. I mean, I had a mother there talking about her 3-year-old son who had 7 surgeries. So multidisciplinary teams are great, as long as you don't have one specialty try to trump everybody else. And the other thing is, always have patient input. And I'm talking about adult people with DSDs. Don't say these advocates are gender dysphoric, horrible people that we don't want to talk to because they hate surgeries. That is not true. Some of us had surgeries that they wanted because they thought at one point in time, yeah, that might be a good thing. So it's not that we're generally against everything. We're just against enforcing something that could potentially be devastating to that person's life in the future. And I know that it's very difficult to make the transition from little baby to this baby having sex. I understand that's, if parents look at the baby, they see their little baby, they don't see the adult who wants to have sex with somebody. But that's what these advocates can do for a multidisciplinary team. So if you ever think about creating one, please reach out to the community and find community advocates. And I'm pretty sure that none of them will have just an agenda of, oh, we hate surgeons and we don't ever want. They will work with the parents, but they should at least give the parents a chance to talk to one person who's been through this. Because this mother in Cincinnati, I asked her specifically after she talked, never got the chance to talk to anybody.
Really quick, the big thing for these multidisciplinary teams, like with DSD patients, leave the clit alone. Always. If they can void, leave it alone. If they want to get it smaller later in life, that's fine. It's had plenty of time to develop. Don't do what they did to me, where they removed 80% of the sensitive tissue. Gone. So just leave it alone until they're an adult. That's like 100%.
I think the other thing that's missing at the moment that would be really good to have in a multidisciplinary team is trauma expertise. A lot of what we've been through, as you've heard, it is akin to rape trauma. The kind of genital interventions, it is akin to rape trauma, and that trauma gets really somaticized in the body. I was privileged as an addiction expert, 10 years sober, to go to the refuge rehab in Florida to do 3 months of residential trauma work. and still I have trauma that's emerging, but I think that needs to be built into the program from the very beginning, because some of the stuff that's still going to have to be done is going to create trauma, and nearly everybody you see is going to have trauma, which they might be medicating with drugs and alcohol or food or self-harm. We don't know how many intersex people self-harm or are addicted or killed themselves. The stat doesn't exist as far as I know, and certainly rehabs and treatment facilities don't have the expertise to deal with intersex patients, and aren't actively seeking to work with our population. We're completely invisible. I think it's probably akin to the trans community, possibly even higher.
Yeah, peer support is huge, and there is a national, in the United States, there is a support group this summer. That conference is in Chicago. If you want information about that, please contact Michael, and we'll get you the link to the primary U.S. group. I've been involved with it. Allison's been involved with it. Seven now that you may get involved with it. And the most important thing is for your patients, your young patients, or even as adults, find other intersex people like themselves. I just wanted to acknowledge Vernon Rosario here. He's one of the first people I met when I was on my journey, and he had a question. He's been an early ally in the intersex community, and so if you have a question,
So to answer your question, yes, UCLA does have a Intersex DSD disciplinary team that I would be psychiatric training on for 2 years and 2 years ago. And it was a very humbling experience because we learned, like hopefully all you learned here today, that intersex conditions are incredibly diverse. Even under the same diagnosis, the bodies are very different, let alone people's psychologies. And that what was fascinating to me is that the majority of kids at UCLA do not have a clear diagnosis, and many of the older kids who are coming in with the clinical diagnosis, that diagnosis does not hold up. So many older adults have some diagnosis in their history that everybody's working with, but that may not be correct.
Story is unfolding throughout the lives.
The bodies, the syndromes are really complicated. As medical professionals, you have to put a lot of work into learning about your individual.
You're going to earn your paycheck with the intersex program. You better eat your Wheaties.
All right, sorry to cut the discussion short, but thank you to the panelists and Dr. Kreuzer for joining us. All right, so we're almost done with the program, so essentially go ahead and head back to Beyer Hall, or auditorium, where the opening speaker was.